So continuing with our discussions of anatomy and physiology, with movements being our central point of meaning or the central point in our semantic network, we are looking at lumbar extension here. So in looking at lumbar extension, our main objectives are to have a specific discussion of what lumbar extension is. So discussing planes and axes. Again, this is extremely repetitive, very much on purpose. General discussion of the muscles that extend the lumbar column. This will be extremely similar to what was spoken about with respect to the thoracic region, with minor differences, at least as far as vasculature is concerned. A general discussion of the nerves that supply the muscles of lumbar extension, general discussion of the vascular supply for these muscles, very superficial discussion of the midgut. So the midgut consisting of the second half of the duodenum, which is subsequent to the duodenal papilla. Then we will have a discussion, which would then continue on rather, with the jejunum and the ilium, then a very general discussion of areas to assess and treat should lumbar extension issues be suspected or reported by the patient. So lumbar extension. So first we speak about the cuts or the planes. So a sagittal cut or the sagittal plane is a 50% cut of the body left to right. The horizontal or transverse plane is a 50% cut of the body top to bottom. The frontal plane is coronal plane is a 50% cut of the body front to back. Axes being perpendicular, sagittal plane, transverse or horizontal axis, horizontal plane, vertical axis, or transverse plane, vertical axis, frontal or coronal plane, PA or AP axis. So lumbar extension, because it has an axis, would be considered a rotation or rotatory movement. But again, as we repeat consistently, we don't use the term rotation because rotation is the term that is commonly used for motion in the horizontal plane or the transverse plane about the vertical axis. So in the case of lumbar extension, we're talking about backwards bending in the sagittal plane. As far as muscles of lumbar extension are concerned, you will see some variation here, or you'll see some other muscles added in, but your primary muscles are going to be the erector spinae, so the iliocostalis lumborum, the longissimus thoracis to some degree, just because of connections, the spinalis thoracis. So what you have a large amount of is the thoracolumbar fascia in there. So as you can see in the lumbar region, you have a lot of connective tissue. So if you look primarily at the diagram on the left of the screen, you'll see a large amount of connective tissue in that artist's rendering in the lumbar region. And what that will generally suggest is that, again, the motion that is going to generate lumbar extension is primarily going to be torso or trunk extension. So you have an iliocostalis lumborum, you also have an iliocostalis thoracis. But as far as the longissimus and the thoracis are concerned, or sorry, the longissimus and the spinalis are concerned, you have more so spinalis thoracis and longissimus thoracis, but they connect to that common tendinous sheath. So what you're seeing is, again, the majority of extension is generated muscularly within the region of the thoracic portion of those muscles. Now you do have the deeper paravertebral muscles or intervertebral muscles in the intertransversae, interspinalis, multifidus, and rotatories. They are going to generate extension to some degree, but for the most part, what we're looking at really is trunk extension, which will then include lumbar extension. As far as additions to this, you will have some people argue for the QL being a bilateral extender, but the QL is essentially directly beside the transverse processes. So it wouldn't really have an angle of pull to generate anything with respect to lumbar extension. Some people will argue differently. Some people will also argue that bilaterally the latissimus dorsi, because it attaches to the thoracolumbar fascia, can do it. Usually the argument that I see, or the description that I see, is that the lats would generate torso rotation. It's not impossible that in some people they could generate some torso extension, but for the most part, it is not noted. So you can have that discussion, you can include it, you can exclude it. I would say, generally speaking, what you're really looking at is the erector spinae as a group with the thoracic and lumbar components therein. The interspinal or intervertebral muscles are much less powerful, so they're not likely to contribute to this largely. It doesn't mean they're not involved. They're obviously involved. They're in the region. As far as neural tone to all of those muscles, at least the erector spinae and the intervertebral muscles, you look at the dorsal primary rami. So if you're looking at the diagram, the SPs or the spinous processes are pointing downwards. So what you have is the top picture being the spinal cord, and then the anterior primary rami being forwards, the posterior primary rami going backwards, right? So they all kind of mix as they come out, and then you're going to see the stuff going backwards to the paravertebral musculature. All of the erector spinae and the intervertebral muscles are going to receive motor tone from the dorsal primary rami. So you've got the muscles along the vertebral column getting innervation from the dorsal primary rami. You also have the skin associated with each segment, essentially having sensory innervation from the dorsal primary rami. As far as the arteries that are going to supply the intervertebral muscles, or sort of the intervertebral muscles, as well as the erector spinae in the lumbar region, you're looking at the lumbar arteries. So the lumbar arteries are analogs to the intercostal arteries in that they come directly off of the abdominal aorta, where the intercostal arteries come off of the descending or thoracic aorta and then innervate related structures. So they're directly against the vertebrae, more or less, of the aorta sitting essentially anterior to the lumbar vertebrae, the abdominal aorta. It will give off some branches that will then supply structures in the region, with arteries going backwards to the paravertebral musculature, so the intervertebral and the erector spinae. And then that is going to enter into, as far as the venous drainage is concerned, enter into the lumbar veins. Now, those lumbar veins are going to more or less enter the azygous system. So they're not going to enter the inferior vena cava, they're going to enter the azygous system, and as they travel up, so it's the lumbar veins there. As they get into the thoracic region, they are considered the azygous veins on the right, and the hemiazygous on the left as it enters, and then on the top of the left side, it's the accessory hemiazygous. So the cord and the vertebral musculature are mostly emptying through the azygous system before entering essentially the, I believe it is the superior vena cava, maybe the inferior vena cava. I'm not 100% sure where the entry point from the azygous system is, at least not off the top of my head. Now, the other thing to just very generally note, we're not necessarily doing a bunch of discussion around the lymphatic system. The lymphatic system within the lumbar region, you're going to have various nodes, so various lymph nodes in various regions, which will be named for the region, but essentially they all are going to come together around cisterna chyli. Cisterna chyli, depending on the source that you read, is going to be in the area of L1, L2, and that's going to ascend through the diaphragm along the vertebral column, and that is going to become the thoracic duct. So basically all of this is coming central, hitting cisterna chyli, going up through the thoracic duct. So the entire lower body, the entire abdomen is going to go up to the thoracic, essentially the thoracic duct, which will then empty into the left side. The only things that are drained otherwise lymphatically, right side of the head, right arm, which is the right lymphatic duct, but everything else in the body is going to eventually end up in the thoracic duct, which is going to empty into the left subclavian vein. So to discuss the midgut is the second half of the duodenum, the ileum, the jejunum, and I forgot to mention the ascending colon, so the appendix, the cecum, the ascending colon, and then the first 2/3 of the transverse colon would be considered the midgut. The midgut is going to receive arterial supply off of the second unpaired artery off of the abdominal aorta, which is the superior mesenteric artery, and it is then going to give off branches. Now, the manner in which it does this is it travels through the mesentery proper. So I believe it's around the level of L1 or L2. It's going to essentially go forwards, but as it goes forwards, it enters the mesentery proper. The mesentery proper being generated by folds of the peritoneum that are going to suspend varying portions of the abdominal contents, or all of them, essentially in some way, shape, or form, cordon them off or separate them from one another, but also support and suspend them so they don't just fall right out. And one of those folds ends up being the mesentery proper, and it essentially runs somewhat high on the left to low on the right. And as it does that, it's going to give off arterial branches. So you can see off of there, you have the right colic artery, the ileocolic artery, the middle colic artery, the jejunal and ileal arteries, and there's going to be some supply to the duodenum as well. But that is how they're all essentially connected. As far as the arterial supply, the neural supply to all these structures is going to follow the superior mesenteric artery and its branches. But the other thing is that they're all connected in this fashion, primarily because they pass through the mesentery proper, which is a fold in the peritoneum. Now, the sympathetic side, if you look at the right side, the picture on the right side, you see the SG, the stellate ganglion, thoracic ganglion 2, 3, 4, so on and so forth. The superior mesenteric artery and the midgut, or essentially following the superior mesenteric artery, you're going to get the lesser splanchnic nerve. So the lesser splanchnic nerve is going to be T10-11. So on the right side, you can essentially see the fibers coming together there, and then it's going to descend through with the abdominal aorta at the aortic hiatus, and then it's going to. So those are postganglionic fibers from the thoracic ganglia, or for the sympathetic chain ganglia. But then when they hit the next ganglia after the lesser splanchnic nerve, then what you're going to get is those are preganglionic to the next ganglia, and then those are going to be postganglionic, the fibers from there, to follow the superior mesenteric artery. So again, you can see how they descend, and also on the picture on the left, you can see how they descend with the abdominal aorta at around T12 going through the diaphragm, and then they're wrapping around the abdominal aorta to hit their subsequent ganglia and then become fibers that go towards specific structures. Now we're looking at the superior mesenteric ganglia, named for its relationship to the superior mesenteric artery. That superior mesenteric ganglia, as again, so from the sympathetic chain ganglia, you have postganglionic fibers, which become the lesser splanchnic nerve, which then synapse at the superior mesenteric ganglia. But to that, they are preganglionic. Then you're going to have postganglionic fibers that will go out to the midgut. So second half of the duodenum, the ileum, the jejunum, the appendix, the ascending colon, first 2/3 of the transverse colon. And they will do that by traveling through the mesentery proper in association with the superior mesenteric artery and its branches. Now, the midgut function, so the distal half of the duodenum, is essentially acid-base balance with bicarbonate from pancreatic juice. So that's really aimed at the chyme itself. So essentially the partially digested bolus of previous food that has come through the first half of the duodenum from the stomach, coming from the stomach, is quite acidic. So the bicarbonate in pancreatic juice is going to neutralize that, bring it back to a neutral place. The bile coming from essentially the liver to the gallbladder through the common bile duct into the major duodenal papilla, which is kind of your halfway mark, is going to help break down fats. From pancreatic juice, you're going to have a breakdown of proteins and carbohydrates as well from structures within the pancreatic juice. Once you get to the jejunum, what you're looking at is the vast majority of absorption of nutrients and water. So that's where a lot of that absorption happens. It's not that it doesn't happen in the other locations. It's just that most of it's going to happen in the jejunum, superficially speaking. Once you get into the ileum, you're going to have some absorption of nutrients and water, as well as immune function. So the Peyer's patches, you essentially have folds. Those folds are attempting to trap stuff and monitor the contents of the ileum primarily. There are Peyer's patches throughout the small intestine under some assays, but for the most part, they're most concentrated in the ileum, and even more so at the end of the ileum. So what it's really trying to do, or the claim is, it's really trying to monitor the contents of the ileum, or the small intestine broadly, but more so the ileum, to identify anything that is foreign that needs an immune response mounted against it. So it's essentially a monitoring and immune function with the Peyer's patches. So the ileum is where most of that happens. There is obviously absorption of nutrients and water, but mostly the ileum is going to be concerned superficially with immune monitoring and immune response. The appendix seems to be a storehouse for bacteria, as well as, so if there was, say, a course of antibiotics that wiped out the bacteria in the gut, the appendix does have some left and it can help repopulate. That's what they believe at the moment. There is immune function. I believe it is some Pyrus patches within the appendix, so there is some degree of immune function associated with the appendix as we understand it. Now, it's not absolutely necessary because we do have proof over a long time of believing it was a vestigial organ of the ability to remove the appendix and still have immune function maintained. So it contributes to some degree. It is not necessarily required for life, but it does have function. Right, it used to be considered a vestigial organ. We have identified function, obviously still under increasing or continuing investigation. The colon is absorption of whatever's left over to turn it from chyme to fecal matter. So they're essentially in the colon, so the ascending colon in this case, and the first 2/3 of the transverse colon you're looking at absorption of leftover water and micronutrients. Now, just a special note, because I didn't necessarily say it when I was speaking about the sympathetic side of the innervation, following the superior mesenteric ganglia and its branches going out with the superior mesenteric artery, is that the parasympathetic side is still the vagus within this region. So essentially, the cutoff is the end of the first 2/3 of the transverse colon. Everything up until there is parasympathetic from the vagus nerve. There may be some mixing in particular individuals where the fibers may go shorter or farther than that first 2/3 of the transverse colon, but generally speaking, that is what you will hear in most resources. That is where the vagus is expected to end its parasympathetic innervation. As far as areas of consideration for assessment and treatment with respect to specifically lumbar extension, you're considering mostly the erector mass, lumbar vertebrae, the ribs, and the hips. You may want to consider the T-spine to some degree because, as we noted, realistically, lumbar extension is much more coupled with trunk extension generally, especially because of how the muscles run. So it's not necessarily an isolated movement that would occur often. It is going to occur in some relationship to thoracic extension. So you may want to consider thoracic vertebrae as well, at least to check them. Then the hips, because of connection to the lumbar column, you may have co-occurring findings between the hip and the lumbar region, and obviously the lumbar vertebrae. Now, remembering that lumbar extension isn't just to test lumbar extension, you don't extend it, you flex it. So if you have reason to believe that it is extended, you must do its opposite to check it, to prove that it will not do the opposite. So it is not extended unless it will not flex. As far as things to be careful of or stay away from, known or suspected fractures or tears within the region, so be it a possible pelvic fracture, possible lumbar fracture. The tears would also include, at least in the lumbar region, more obviously, the possibility of tears of the annulus fibrosus, which most people will term a herniation or a bulge, rather. So it's a bulge when the internal portions of the annulus begin to tear. So the nucleus pulposus in the disc will start to push out a little bit. It is considered a herniation when the annulus fibrosus tears entirely, at least in a small spot, so that the contents of the nucleus pulposus come up. I would tend to term that a tear because the annulus fibrosus is soft tissue and it has torn, thus allowing the nucleus pulposus to peek out into areas where it's not supposed to. So it would then be contained by various intervertebral ligaments. Now, that said, you may also have some tears of the abdominal wall. You may have some tears within muscles in and around the hip. So it's less likely that you're going to have a tear of the erector mass, especially in the area of the lumbar region, because mostly it's connective tissue. So it's mostly tendinous there. The other thing to consider is known or rebound tenderness of the abdominal wall. So rebound tenderness is if you put pressure on the abdominal wall and it doesn't hurt and you let go and it hurts. That is essentially a visceral pathology that requires medical attention until proven otherwise. So that is something where there could be a deep problematic visceral pathology that would not be attended to in most parts of the world by osteopathic practitioners. It would be attended to by physicians. Now, the other deal, as noted in the lumbar flexion discussion, known or suspected abdominal aortic aneurysms. These are much easier to identify in the abdominal region because even in people who are not particularly lean, when they're in supine, the abdominal wall will notably bound. It will be very pronounced. So if you see a lean person, it's not abnormal to see some bound in the abdominal wall when they're laying and they're essentially not in active breathing or the breath has paused for a moment. It's not that strange to see the abdominal wall bound, at least to a small degree, but a pronounced bound to that abdominal wall in relation to the abdominal aorta is notable in lean people. It is also notable in people who are not as lean. So you can identify this visually, at least superficially. So if you see the abdominal wall bouncing in a way that you think is concerning, you would want to refer out for some form of examination prior to treating, because again, you don't want to put excess pressure through that weakened abdominal aortic aneurysm. So in the area of the aneurysm, the wall is essentially weakened. You don't necessarily want to put undue pressure through that and possibly cause a very bad day for yourself or your patient. So again, you're generally looking at the lumbar region itself, so the erector mass, the lumbar vertebrae, the ribs, because there is going to be some connection muscularly, so especially iliocostalus thoracis, being able to exert some torso extension to create lumbar extension, you may want to consider it through there, and then the ribs themselves and the hips. So as I noted, the ribs. No fractures and tears, which is consistent. I would include disc herniations or disc bulges as soft tissue tears. So if you conceive of them as soft tissue tears, you will treat them more appropriately, as opposed to generating large amounts of motion and possibly disrupting the tear a little bit more or causing some aggravation to the patient. Rebound tenderness of the abdominal wall. So again, pushing on the abdominal wall, no pain, you let go and it hurts. That's a visceral pathology until proven otherwise. Then known or suspected abdominal aortic aneurysm. So those are things you want to consider and be careful of.